Good morning. I convened this hearing of the Subcommittee on Oversight and Investigations. We are here today to discuss a continuing and increasingly expensive problem, waste, fraud, and abuse in the Medicaid program. I guess one way I could put this is for centuries people have tried to deal with the issue, is there life after death? And apparently there is in Medicaid. And we'll get to the bottom of that today. Last year, the Medicaid program provided medical services for approximately 60 million people at a cost of $310 billion. But during that same year, the Centers for Medicare and Medicaid Services estimate that the improper payment rate was 6.7% or $17.5 billion. This is an increase of almost 1% or over $3 billion from the previous year. It's a troubling trend, especially as the program continues to expand. Unfortunately, the Medicaid program is far too accustomed to fraud. In fact, the Government Accountability Office has designated the Medicaid program as a high risk for fraud and abuse since 2003, and it's been the subject of multiple GAO and Department of Health and Human Services Office of Inspector General reports over the past several years, including a GAO report being highlighted today. In 2012, the committee requested GAO identify and analyze indicators of improper and potentially fraudulent payments to Medicaid beneficiaries and providers. In a just-released study, another in a long time examining Medicaid fraud, GAO has reported that CMS needs to take additional actions to improve provider and beneficiary fraud controls. GAO found that thousands of Medicaid beneficiaries and hundreds of providers in just 4 states, Arizona, Florida, Michigan, and New Jersey, were involved in possible improper or fraudulent payments during fiscal 2011. For example, almost 200 deceased beneficiaries received at least $9.6 million in Medicaid benefits. About 8,600 beneficiaries received payments by 2 or more states totaling at least $18.3 million. The Social Security numbers for about 199,000 beneficiaries did not match the Social Security Administration databases. About 90 medical providers had their medical license revoked or suspended in the state in which they received Medicaid payments. At least 47 providers had foreign addresses as their location of services, including Canada, China, India, and Saudi Arabia. About 50 providers who received Medicaid payments were excluded from the federal program for a variety of reasons, including patient abuse or neglect, fraud, theft, bribery, and tax evasion. GAO acknowledged that regulations issued in response to the Affordable Care Act may have addressed some of the improper payment indicators found in GAO's analysis. For example, CMS created a tool called the Data Services Hub to help verify beneficiary application information. But questions remain whether this tool has been properly implemented and if the states have been able to effectively use this tool to combat waste and fraud. In fact, just a few weeks ago, a Reuters report found that more than 1 in 5 of the thousands of doctors and other health care providers in the U.S. prohibited from billing Medicare are still able to bill state Medicaid programs. The report included disturbing stories such as a Georgia optometrist who claimed he conducted 177 eye exams in one day, yet remained on South Carolina's Medicaid rolls for almost a year after he pleaded guilty in Georgia. In another instance, an Ohio psychiatrist routinely over-reported the time he spent with patients and even billed for no-show patients. CMS revoked his billing privileges after he was convicted of felony workers' compensation fraud, yet he continued to work in the Illinois Medicaid program, getting paid $560,000 for services or prescriptions he wrote after his Medicare provider revocation. Shockingly, on the day he was being sentenced in Columbus, Ohio, he also claimed that he saw 131 group therapy patients at his Illinois practice. Now, these stories we know are unacceptable. Medicaid fraud undermines the integrity of the program, denies our most vulnerable the services they deserve, and wastes taxpayers and hard-earned dollars. I hope we'll hear today about the steps that can be taken to further combat fraud in the Medicaid program. That's what we want to focus on. And GAO has recommended some common-sense steps that would reduce fraud, such as issuing guidance to states better identify beneficiaries who are deceased and the availability of automated information through Medicare's enrollment database. In light of the history of fraud in the Medicaid program and its growing size, however, will these steps be enough? Will we be here again in another 2 years discussing the same thing? And with the Medicaid program continue to expand, the committee is concerned that the opportunity and motivation to defraud the program will only increase. So I'd like to thank our witnesses who are here today. You have the ability to save the taxpayers a massive amount of money. We hope to hear from you today how you plan to do that, and we're grateful for your presence. And I now recognize the ranking member, Ms. DeGette of Colorado, for 5 minutes.
Thank you, Mr. Chairman. Good news on a bipartisan basis. We're against waste, fraud, and abuse, as usual, in the Medicaid program and every place else. I've been on this subcommittee now 19 years, and we've had a whole series of hearings over the years. And as you accurately point out, Mr. Chairman, it goes from administration to administration. Medicaid seems to be particularly vulnerable to issues like fraud, and we have to continue our oversight. So when you say, will we be here again in 2 years? Probably. We'll probably be here in 10 years because this kind of a problem takes ever vigilance by this committee. The GAO report we're talking about today tells us that the Medicaid program, like many other large programs like Medicare, defense contracts, and private insurance plans, experience thousands of improper and possibly fraudulent payments every year. Last year, CMS found an estimated improper payment rate of 6.7%, which amounted to about $17.5 billion for the Medicaid program in 2014. Now, as I said, and you said, like many other programs, Medicaid is not, fraud is not unique to this committee. In our report, which was published in 2003, which was 12 years ago, we said, quote, committee hearings last year revealed that the cost of the Medicaid fraud program could exceed $17 billion every year. This year, 2003, the committee will examine ways in which states could adopt more rigorous enrollment controls to keep unscrupulous providers out of their programs and improve their program integrity standards. And we had laudable efforts since that time. Truly $17 billion in 2003 and about $17 billion now, even with the Medicaid expansion. That's not something to be proud about, although I guess we should be glad it doesn't seem to be getting a lot worse. Nonetheless, Congress and the administration and the governors all across the country need to focus on improper payments. There's something exciting, though, that I think may actually make a major difference going forward. Under the Affordable Care Act, a number of important measures were enacted to prevent or reduce improper payments in the Medicaid and Medicare programs. For example, the ACA provided nearly $350 million in new funds for anti-fraud efforts. It provided new authorities to the Secretary of HHS to help shift from a traditional pay and chase model to a preventative approach by keeping fraudulent suppliers and providers out of the program before they commit fraud. And now we have in place a host of new and enhanced anti-fraud penalties to deter those attempting to improperly bill Medicaid or Medicare. These are important new tools, and I think they can help safeguard the program. I'm looking forward to hearing from CMS and GAO on how these efforts are working and how they expect to build upon efforts to strengthen Medicaid at both the federal and state levels. I think it's important to put this discussion of improper payment rates in context with large-scale financing of other public and private sector programs. For example, I can cite endless examples of major defense contractors receiving improper payments from the Pentagon. Last year, the Washington Post revealed that one company improperly charged the government more than $100 million for services. DOD alone reported that it had made $1.1 billion in improper payments for fiscal year 2011. You know, overbilling occurs across all sectors of the government, and we have to figure out why that's happening and how we can strengthen our financial controls across the government to prevent this kind of overpayment and fraud and find new ways to protect taxpayers. And so I think the GAO does a really important job both here in helping strengthen the Medicaid program and many other places. I have a lot of questions about the finding and recommendations, some of which may go beyond the scope of the report. For example, and this is in context of the ACA too, the audit relies on data from fiscal year 2011. As we implement these ACA provisions that have gone into place since that time, I'd be interested to know, are they really making a difference on the data in the 3 or 4 years since that time? The other issue we need clarification on is the basis of the 4 states that were chosen for this audit. So, as I say, I really want to thank the agencies for coming in and helping us. Anything we can do to strengthen the controls to prevent overpayment and fraud is great with me, because the hardworking Americans in all 50 states rely on these Medicaid services, and they also rely on the fact that their tax dollars are going to best serve this country. Thank you, Mr. Chairman.
And thank you. Now I'll recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. This is an important hearing we're having today. Medicaid, a program that is entirely under our jurisdiction in the Energy and Commerce Committee, is a vital program that covers and provides care for some of the nation's most vulnerable populations. This committee does have exclusive legislative jurisdiction over Medicaid, and it is our responsibility to ensure that the long-term sustainability of Medicaid is assured through proper oversight. Inefficient and misdirected payments within the Medicaid program have substantive budgetary, access, and provider impacts that ultimately affect patients. If states do not have the proper tools available for monitoring and enforcement, there can be lasting effects on the nation's Medicaid recipients and the providers of their care. CMS has reported improper payments well over $17 billion for fiscal year 2014 for the Medicaid program, an increase of nearly $3 billion from the prior year. That is a trend that should concern all of us. Each of those dollars that is spent inappropriately is a dollar not spent on a patient and is in fact a wasted taxpayer dollar. I do want to point out that the recently passed H.R. 2, that this committee had a great hand in getting started and shepherding through the legislative process, and ultimately it was signed by the President, but it did have a number of anti-fraud provisions contained within. Most of those pertain to the Medicare system, but I do wonder if some of those examples may not also be extrapolated to the Medicaid system. Specifically, Mr. Chairman, Section 502, preventing wrongful Medicare payments for items and services furnished to incarcerated individuals, individuals not lawfully present, and deceased individuals. That may be something worthy of study that the CMS may want to consider for the Medicaid system as well. I'm also concerned about allowing entities engaging in fraud to continue to receive federal funds. We want to ensure provider participation in Medicaid, and patients should never be faced with the choice of no care or low-quality care from those providers. The Office of Inspector General has the authority to exclude entities that employ deceptive business practices within the Medicaid program. In 2014, Ranking Member DeGette and I looked into the practices of certain dental management service companies within the Medicaid program, which not only provided managerial services to dental clinics, but also, in fact, actually own these clinics and have direct control over the operations and finances of the clinics. We became very concerned because this corporate structure was resulting in failure to meet basic quality and compliance standards. Unfortunately, many of these practices have continued despite federal government intervention. The Office of Inspector General may initiate a corporate integrity agreement, but these deceptive entities may dissolve under bankruptcy only to reemerge under new management. The Office of Inspector General has the authority to exclude individuals and entities that have engaged in fraud and abuse related to federal health programs, including Medicaid. Following our investigation, we sent a letter to the Office of Inspector General recommending that OIG consider excluding any corporate entity that employs deceptive practices that result in substandard care. So we're grateful that some action was taken over that, but it is incredibly important that there be a way to exclude someone who's engaged in a deceptive practice and prevent that process of dissolving and then reemerging in another corporate form. We must ensure that states have the proper tools available to ensure that tax dollars are never fraudulently wasted in the Medicaid program and that access for Medicaid beneficiaries is subsequently protected. Mr. Chairman, I thank you for the recognition for the time, and I will yield back.
Chairman yields back. I'm not sure if there's anybody else on our side who wants the remaining 50 seconds, and if not, we'll move over to the Ranking Member, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. For decades, Medicaid has been a lifeline for tens of millions of hardworking Americans across the country. That's why we must make sure that the resources we devote to this program are administered efficiently and effectively. Every dollar lost to misuse or fraud of our federal health programs is one less dollar available to fund essential life-saving medical services for Americans. Cutting down on waste, fraud, and abuse is and must remain a priority for CMS, state Medicaid programs, and this committee. Some of my colleagues on the other side of the aisle have expressed concerns that expansion of Medicaid will put state budgets in an untenable position and increase fraud, and that's simply not true. Beneficiary access and program integrity efforts are not competing goals. Smart, effective regulation reinforces both goals simultaneously. In the short time since states have had the option to expand Medicaid, those states have already realized significant qualitative and economic benefits as uncompensated care rates drop and states are able to collect more revenue. Expansion makes good economic sense and good moral sense. For instance, in my home state of New Jersey's projects a nearly $150 million decline in charity care in fiscal year 2016, with savings from the Medicare expansion totaling nearly $3 billion through 2020. Let's also not forget that Medicaid coverage lowers financial barriers to access, increases use of preventative care, and improves health outcomes. Making the program available to more vulnerable Americans is a great achievement and one that I'm very proud of having played a part in. But of course, it's now more important than ever that we act as good stewards of Medicaid dollars and ensure that the benefits of this program are available for generations to come. That's why when we passed the Affordable Care Act in 2010, we included a number of measures to strengthen program integrity and reduce fraud in the Medicaid program. In 2011, for example, CMS established procedures to screen providers and suppliers based on their risk levels so we can prevent fraud before it occurs. This has changed the traditional pay and chase model towards a preventive approach by keeping fraudulent suppliers out of the program before they can commit fraud. There are a number of other ACA anti-fraud measures that have impacted the Medicaid program positively over the past few years. These include new and enhanced penalties for fraudulent providers. These new authorities allow the Inspector General to exclude from Medicaid any provider that makes false statements on an application to enroll or participate in the program. The ACA also requires state Medicaid agencies to withhold payments to a provider or supplier pending investigation of a credible allegation of fraud. The law also significantly increased funding to fight Medicare and Medicaid fraud. So I want to hear today about how all of these measures have worked and about how CMS is implementing regulations to better protect patients and legitimate providers. Although the ACA made significant steps to reduce fraud and abuse in the Medicaid program, I know there's always room for improvement, and I'm glad the GAO is here today to share their findings and provide constructive advice about how we can make the Medicaid program even stronger. But I want to caution against applying GAO's findings too broadly. First, the analysis focused on 4 states, Arizona, Florida, Michigan, and New Jersey, and its findings are not generalizable across the country. Second, the report looked at data from fiscal year 2011 before many of the ACA anti-fraud provisions went into effect. GAO acknowledges several times in the report that CMS has since made changes to address improper payment issues. Third, I want to make the point that many of the potentially improper payments listed in this report are likely examples of provider fraud, not beneficiary fraud. The GAO report lists examples such as billing under deceased beneficiaries' identities or billing on behalf of currently incarcerated beneficiaries. Given that these beneficiaries are hardly in a position to defraud the government, I think it's likely that many of these are examples of provider fraud. So, Mr. Chairman, good program integrity helps to ensure that beneficiaries receive the care they need, so I look forward to hearing from CMS and GAO how these latest efforts are being implemented by the states. I guess, I don't know if anybody wants my 30 seconds, but otherwise I'll yield back. Thank you.
Thank you. I appreciate that. We will proceed onward. It's good to see we're all on the same team today, focused on this, and our witnesses are part of this too. So I'd like to introduce the witnesses for today's panel. Make sure you get the names right. It's Seto Bedoyan. Did I get that right? Good. Thank you. The Director of Audit Services in the U.S. Government Accountability Office, Forensic Audits and Investigative Services Missions Team. Welcome here. Dr. Shana, I know this, Shantanu Agrawal. You've been here before. Welcome back. As the Deputy Administrator and Director of the Center for Program Integrity at the Centers for Medicare and Medicaid Services. I will now swear in the witnesses. As you are aware, it is the committee's holding investigative hearing to, when doing so, has a practice of taking testimony under oath. Do either of you have any objections to testifying under oath? Neither of you do. Thank you. So as the chair then advise you that you, under the rules of the House and rules of the committee, you are entitled to be advised by counsel. Do either of you desire to be advised by counsel during your testimony today? And both of you say no to that. So in that case, if you please rise, raise your right hand. I'll swear you in. You swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth. Thank you. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute summary of your written statement. You know how to watch the red light in front of you. Stick with that, and I guess we'll start off with Mr. Bedoyan.
Chairman Murphy, Ranking Member Daggett, and members of the subcommittee, I am pleased to be here today to discuss results of GAO's recent report on Medicaid beneficiary and provider fraud controls. As you know, and as you mentioned, Mr. Chairman, Medicaid is a significant expenditure for the federal government and the states, with combined outlays of about $516 billion in fiscal year 2014, involving millions of beneficiaries and providers. These numbers, as members mentioned, are all expected to grow as a result of the expansion of Medicaid under the Affordable Care Act. A program of this scope and scale is inherently susceptible to error, including improper payments, as well as fraudulent activity. In fact, as mentioned again, CMS reported an estimated improper payment rate of 6.7% or $17.5 billion for Medicaid in fiscal year 2014, compared to 5.8% or $14.4 billion, respectively, in FY 2013. Also, earlier this year, we reported that Medicaid remains on GAO's high-risk list, in part because of concerns about the adequacy of fiscal oversight of the program, including improper payments. With this backdrop, I'll now discuss our report's key findings. Overall, we found thousands of Medicaid beneficiaries and hundreds of providers were involved in potentially improper or fraudulent payments during fiscal year 2011. The most recent year for which reliable and comparable data were available in the 4 selected states we reviewed, namely Arizona, Florida, Michigan, and New Jersey. These states accounted for about 9.2 million beneficiaries and about 13% of all fiscal year 2011 Medicaid payments. More specifically, examples of potentially improper or fraudulent payments include about 8,600 beneficiaries had payments made on their behalf concurrently by 2 or more of the selected states, totaling at least $18.3 million. The identities of roughly 200 deceased beneficiaries received about $9.6 million in Medicaid benefits subsequent to the beneficiary's death. Some 3,600 individuals received about $4.2 million worth of Medicaid services while incarcerated in state prison facilities. 90 providers had suspended or revoked licenses in at least one state in which they received payment. Associated Medicaid claims totaled at least $2.8 million. To its credit, as again mentioned in opening statements, CMS has taken some regulatory steps to make the Medicaid enrollment process more rigorous and data-driven. However, gaps in beneficiary eligibility, verification guidance, and data sharing persist. For example, in 2013, CMS required states to use electronic data maintained by the federal government in its Data Services Hub to verify beneficiary eligibility. According to CMS, the hub can verify key application information, including state residency, incarceration status, and immigration status. However, CMS regulations do not require states to review Medicaid beneficiary files for deceased individuals more frequently than annually, nor specify whether states should consider using the more comprehensive Social Security Administration's full death master file in conjunction with state-reported death data when doing so. As a result, states may not be able to detect individuals that have moved to and later died in another state or prevent the payment of potentially fraudulent benefits to individuals using their identities. Accordingly, additional guidance from CMS to states might further enhance program integrity efforts beyond using the hub. In closing, our findings underscore that as Medicaid's numbers grow as expected, both the federal government and the states need to maximize their efforts to promote program integrity by preventing and reducing potential for improper payments and fraud. Our recommendations to CMS, which the agency has accepted, are designed to enhance its toolbox to this effect, help narrow the windows of opportunity for improper payments and fraud, and provide reasonable assurance that Medicaid eligibility controls are functioning as intended. Mr. Chairman, members of the subcommittee, this concludes my statement. I look forward to your questions. Thank you.
Thank you, Dr. Agrawal. You're recognized for 5 minutes.
Thank you. Chairman Murphy, Ranking Member DeGette, and members of the subcommittee, thank you for the invitation to discuss CMS's efforts to strengthen Medicaid. We share this subcommittee. Enhancing program integrity is a top priority for the administration and an agency-wide effort at CMS. We share the subcommittee's commitment to protecting beneficiaries and ensuring taxpayer dollars are spent on legitimate items and services, both of which are at the forefront of our program integrity mission. I would like to make 3 major points in my testimony today. First, Medicaid program integrity is a shared state-federal responsibility, and I feel strongly that states and the federal government share the goal that the Medicaid program be as secure as possible to ensure beneficiaries are protected and the right payments are being made. Second, we have made important progress in addressing beneficiary eligibility and provider enrollment issues through advanced data systems and improved collaboration. And third, it is clear that more work remains, that we can build on our accomplishments with improved guidance, building more capabilities, and enhanced oversight. States and the federal government share mutual obligations and accountability for the integrity of the Medicaid program and the development, application, and improvement of program safeguards necessary to ensure proper and appropriate use of both federal and state dollars. This federal-state partnership is central to the success of the Medicaid program, and it depends on clear lines of responsibility and shared goals. Although the federal government establishes general guidelines for the program, states design, implement, and administer their own Medicaid programs. Medicaid is currently undergoing significant changes as CMS and states implement reforms to modernize and strengthen the program and its services. While focused on implementation of the Affordable Care Act, CMS has been working closely with states to implement new, more modern delivery system and payment reforms. In the last few years, CMS and states have made important progress in improving the systems and processes that determine a beneficiary's eligibility for Medicaid and that ensure only legitimate providers enroll in and bill the program. We have made great strides. The error rate in beneficiary eligibility, for example, has been cut in half since 2011. We recognize, however, that more remains to be done and continue to work collaboratively with states to further improve Medicaid program integrity. A critical component to preventing waste, abuse, and fraud is ensuring that only legitimate providers have the ability to bill Medicaid in the first place. While states bear the primary responsibility for provider screening and enrollment for Medicaid, CMS is engaging in new efforts to work with states to make sure that only legitimate providers are enrolling in the Medicaid program. The ACA required CMS to implement risk-based screening of providers and suppliers who want to participate in Medicaid. This enhanced screening requires certain categories of providers and suppliers that have historically posed a higher risk of fraud to undergo greater scrutiny prior to their enrollment or revalidation in Medicare, Medicaid, or CHIP. To enroll providers more efficiently, CMS has provided states with direct access to Medicare's enrollment database, the Provider Enrollment Chain and Ownership System, or PACOS, and in response to input from states, began providing access to monthly PACOS data extracts that states could use to systematically compare state enrollment records against available PACOS information. CMS also provides guidance, education through the Medicaid Integrity Institute, which has reached over 4,200 state employees on enrollment and other topics, and oversight through state program integrity reviews. Additionally, the ACA and accompanying federal regulations have enhanced beneficiary eligibility safeguards by establishing a modernized, data-driven approach to verification of financial and non-financial information needed to determine Medicaid eligibility. States now rely on available electronic data sources, including the Federal Data Hub and PARIS system, to confirm information included on the application and promote program integrity while minimizing the amount of paper documentation that consumers need to provide. CMS has also developed its most recent comprehensive Medicaid Integrity Plan in collaboration with our partners, including the National Association of Medicaid Directors, and is working to implement this plan. This work includes providing Medicare data to states for program integrity purposes, expanding support and training of state program integrity staff in vulnerable areas such as program integrity oversight of managed care and evolving integrated care models, and facilitating development of state capacity and access to cost-effective analytics technology. The past several years have brought numerous gains in combating fraud, waste, and abuse in the Medicaid program, but more work clearly remains. Today, the eligibility determination process for beneficiaries and provider screening efforts are significantly more modern and digital than ever before. We thank the GAO for highlighting critical issues in the Medicaid program and look forward to continue to work with states and other stakeholders to establish new initiatives and expand upon our existing programs to fight fraud, reduce improper payments, and improve oversight. Thank you, and I'm happy to answer any questions.
Thank you very much. Let me recognize myself for 5 minutes and keep this moving. We appreciate your input on this and some ideas here. Dr. Agrawal, the improper payment rate for Medicaid program was 6.7% in fiscal year 2014. But that was an increase over fiscal year 2013, where it was just 5.8%. Now, CMS set the target rate for Medicaid payments at 5.6%. So CMS failed to meet the target rate for 2014. Is that correct?
That is correct.
So what was why was the target rate not met?
Yeah, there are three major components of the PERM rate, of the Medicaid improper payment rate. There's a fee-for-service component, a Medicaid managed care component, and then a beneficiary eligibility component. And what I think you see in the error rate is a bit of a mixed picture. So on the one hand, the beneficiary eligibility rate, which was a central topic in the GAO report, did actually decrease from 3.3% to 3.1%. Where we saw the biggest rise was in the provider screening and enrollment standards in the fee-for-service component. What I think the increase shows is that states are at various places of implementing those screening standards, which has led to an increase in the error rate in that part of PERM.
Now, but for 2015, they've set this improper payment rate target at 6.7%, and it's the same rate it was for 2014. It's actually higher than the improper payment rate for 2013 and 2014. So why is CMS actually raising that improper payment rate, that error rate, and for Medicaid instead of lowering it and setting a target for reduction of errors?
Well, I think, we clearly want to make progress on the improper payment rate in Medicaid. The biggest driver right now are those provider enrollment and screening standards. Obviously we want to continue to make progress on the beneficiary eligibility requirements as well. What we find is that states are in various different places of implementing their screening and enrollment for providers. It is a major driver. I think there's a lot of tools that we have to help states make progress, including oversight, education, guidance, giving access to more data systems. But I think we want to set realistic targets and, work our best to make sure states can meet them.
And we want to help you with this. We just want to make sure that the information that this subcommittee gets, this committee gets, can help facilitate that process. But if we raise our tolerance level for errors, and then we say, well, it's all within what we accept, that's not acceptable. So I really want to caution you on that. What I'm hoping that we can not have that goal, but really work towards a goal of how to lower it and then identify those outliers. And I mean, you heard the opening statements. This subcommittee is with you on trying to identify mechanisms for this. Now, the Office of Management and Budget has designated Medicaid as one of 13 programs as high error, and with Medicaid ranking third with $17.5 billion in improper payment amounts. So does CMS know why Medicaid has been designated by OMB as a high error agency, Dr. Agrawal?
Yeah, there are clearly important factors in the size and scope of the program. The fact that the program is administered in numerous, different state Medicaid agencies and require a great deal of collaboration. I'm sure it does also reflect, there are historical error rates. So I think the designation of it being, a high-risk program certainly makes sense. I would also add, just Chairman, to your last question, that part of what we see as the dynamic in program integrity, which is I think important to think about, is that as requirements increase, as the stringency of the program increases, oftentimes we also see an increase in the error rate as a result, because providers or other stakeholders such as states need time to catch up to requirements. I think that's a common underlying element to many factors in the error rate, but specifically the provider enrollment standards that the ACA created.
Well, let me move on to something else here. Director Bedoyan, the GAO has also designated Medicaid as a high-risk program since 2003.
Correct.
What are the criteria that land a federal program into that kind of category, and it's been that way for a long time?
Yeah, for Medicaid, Mr. Chairman, the specific factor that we cited in our report is the fact that its fiscal oversight over the years has been not where it should be. And within that, the
Fiscal oversight at the federal level or state or both?
that would be at both levels, since
Okay.
it's a joint program. And then further within that context, of course, the risk of improper payments and or fraudulent activity contributes to that designation.
And part of this, too, is we see as you're collecting data, you couldn't even get data from some of the states because it just isn't there. Is there things we need to do or things you can recommend as well that what we need to make sure the states have been presenting data so we can analyze it and identify the problem, either one of you?
I would go first. Obviously, data analytics is a growing field, and it would be incumbent upon both the federal government and the states to really pay attention to the quality of their data, the collection, the analysis, the reliability, to make cross comparisons and other analyses.
Well, and what we usually have as our tools in Congress is a carrot or a stick to enhance that. So I'm out of time here, but I'd be looking forward to your comments of what we could do, because without the data, you can't provide accurate recommendations to us. Ms. DeGette, 5 minutes.
Thank you. Dr. Agrawal, in March 2011, CMS put into place new requirements for enrolling and revalidating Medicaid providers and suppliers. Is that correct?
Yes, that's correct.
And the new process separates providers and suppliers into categories of risk, either high, moderate, or limited risk, for additional screening before enrollment or revalidation in the Medicaid program. Is that correct?
That's correct.
And briefly, how does CMS determine which risk category an individual provider or supplier will be put into?
Sure. So these risk categories are done at the provider sort of group level or provider type level. So it isn't an individual provider that would be placed in these various categories. It would be a whole class, such as newly enrolling home health agencies are considered high risk.
I see.
And we designated these risk levels based on input from multiple sources, including the HHS OIG, based on historical levels of fraud or endemic issues with those specific provider types.
Okay, and do the states also have to implement screening requirements before they enroll a provider in the Medicaid program?
They do. Those requirements are largely identical to Medicare's.
And those go into effect March 2016, 5 years after the regulation first went into effect. Is that right?
Many of the requirements have had to be implemented by now already.
Okay.
There were already deadlines. I think what you're referencing is a revalidation deadline,
Right.
yes, is March of 2016.
Okay, and then after everything is either validated or revalidated, it has to be revalidated again every 5 years. Is that right?
That's correct.
Now, is CMS working with the states to implement these new requirements?
We are across the board. So we have largely the same requirements in Medicare and therefore are undertaking the same work in the Medicare program. Where possible, we have made data assets available to states so that they can utilize the results of our screening. For example, I referenced PACOS, where we've done a site visit or fingerprint-based background check. States have access to that data so that they don't have to duplicate those initiatives.
And are the states generally on track with their implementation?
You know, states are in really different places, what we find. So when we do the perm rate measurement every year or do state program integrity reviews, there are certain states that are well advanced in their implementation of these requirements and other states that are lagging quite far behind.
And so I assume those are the states you're focusing on trying to get them.
Correct.
going.
We can increase the number of amount of oversight. We can offer more technical assistance, education efforts, things like that.
Now these efforts were not included in the data of the GAO report, which went for 2011 data. Is that right?
That's right.
Yes or no will work.
Yes.
Thank you. Now, Mr. Bagdoy, in your testimony, your written testimony, which you confirmed in your testimony today in the committee, you said CMS has taken steps since 2011 to make the Medicaid enrollment verification process more data-driven. I'm assuming you're talking about some of these implementations that
Right.
Dr. Agrawal is talking about.
Correct.
Do you think that these steps will help close some of the gaps GAO identified in the report with regard to potentially improper or fraudulent payments?
Sure. As I mentioned in my closing, those steps will definitely add to the toolbox that CMS and the states have and narrow the opportunities for potential improper payments and fraudulent activity. They will probably play out over time, as Dr. Agarwal said. Some states are in different places than others. So
And we have to focus
implementation
on the
will be
ones
key.
who aren't.
That's correct.
Yeah.
Long-term implementation success and sustainability will be key in these areas.
And now, since 2011, do you agree that CMS has taken measures to address some of these real concerns that you raise in your report, like the deceased providers billing Medicaid, providers with the suspended or revoked licenses, and people inappropriately using virtual addresses? Are they working on that now?
I think they are taking steps. They are in the right direction, we believe, but execution and sustainability will be, again, key for both
agree.
the federal government and the states.
Yeah, I appreciate GAO's sustained work on this issue. Oh, excuse me, that's my child. She programmed my phone to bark.
Interesting
when
voice
she
that
called
your
me.
child has.
Yeah, that's my other one. But I'm glad that you both agree that the Affordable Care Act has changed the way we prevent and address Medicaid fraud, and I look forward to it. As we said, Mr. Chairman, we're going to be back here in a couple of years making sure that these ACA requirements have been implemented. Thank you.
Thank you. I now recognize Mr. McKinley for 5 minutes.
Two quick questions. One is the CMS has raised its improper payment rate target from FY 2015 to 6.7% from the 5.6 target rate in 2014. Is that a good internal control practice to raise the target rate?
Are you asking me?
Yes.
No, I do appreciate the question. And again, I think it's important to set realistic targets and goals that do push us to improvement, but at the same time recognize that Medicaid is a state and federal program, that states are in various places of implementing things like the provider enrollment standards, which are the major driver of the improper payment rate at this point.
Okay. Let me get to the question I had from West Virginia. And it's more of a question, I think, of perhaps abuse and errors. Let me frame the argument. In West Virginia, 1/3 of the hospitals we have in West Virginia are critical access hospitals. We're a very rural state. And for nearly 30 years, since the early 80s, West Virginia's critical access hospitals have been using a provider tax to supplement and provide resources for them. In 2012, CMS hired a different auditor from all these past 30 years. And this new auditor stepped in and said, that process isn't approved anymore. And we're going to go back and we're auditing you back until 2009, and we're trying to recover the money that you previously were working under the idea that this was the appropriate way to go about getting a provider tax revenue coming in. This is going to be an incredible hindrance for these hospitals to provide medical care in rural areas of West Virginia when we go backwards on them after they were working under the idea that they thought they were working properly. So we've talked about, can we go forward from here, not go back and try to penalize them for following someone else's advice that was also with CMS. Now we go forward. We've written letters, we've had conversations with it. Until recently, the CMS really was disengaged with us. Now, these hospitals are all getting invoices. 3 years after the 2012, when they were told we're not going to allow that anymore, now in 2015, they're getting invoices that they say they have to pay them within 15 days or they're going to have their funds withheld. First, I don't know of any private sector coming from the private sector. I've got 50 years in the private sector. I've never heard of someone saying, if you don't pay within 15 days, we're taking out of your hide. How they're going that just doesn't work. There's no details on the report on these invoices. And when they've asked, can we get a detail of what this invoice includes? And they're saying that they can't have it. They're being denied access as to what the invoice reflects. So I hope you understand this kind of smacks of bullying on the part of the CMS to rural hospitals, especially given the fact that they were told to use this. This was okay, and now a new auditor has a different opinion. So do you think CMS is handling this crisis in West Virginia and probably in other rural areas of this country Do you think CMS is handling this sensitively and appropriately?
Congressman, I appreciate the question. I can tell you that CMS has definitely been focused on critical access hospitals and rural hospitals in the various policies we promulgate, including payments and other policies. I will tell you, I'm not aware of the specifics of this particular situation. I understand some of the details now from what you've explained. However, I think I'd have to connect you to the other folks in the agency that are directly working on this issue, but I'd be happy to take it back.
If you would, please. We've been given a runaround. Everyone, the fingers, I've never seen so many fingers pointing in different directions. It's not my problem. It's someone else. And we've been trying to pursue that. So if you can help us on that, we'll put you on record. Okay, you're under oath that you said you were going to help. So
thank you, Congressman. I appreciate that. I
will remind you of that in the future. But thank you, because we need to get this result. Remember, a third of the hospitals could very well go under if they have to make these payments. Thank you.
Thank you.
Yield back.
Gentleman yields back. Now recognize the ranking member, Mr. Pallone, for 5 minutes.
Thank you. GAO reports that CMS has made several changes since 2011 to help limit improper payments, and these steps may address many of the potential improper payments GAO found in their analysis of 2011 claims. In addition to noting the progress already made, GAO made 2 recommendations to further improve efforts to limit improper payments by increasing information and data sharing efforts between the federal government and the state Medicaid programs. And GAO first recommended that CMS help states better identify deceased beneficiaries. I want to ask a question of each of you, but I've got 3 sets here, so we've got to go fairly quickly. Mr. Bagdoyan, can you comment on GAO's findings that led to this recommendation?
Well, we did matching of deceased rolls from the Death Master file. That's the complete file that has about 98 million records, and we matched those against claims data, and we discovered those beneficiaries who had been deceased after their or before their services were billed for. So. Okay.
And Dr. Agrawal, what steps is CMS taking to implement this recommendation?
Yeah, we take the recommendations very seriously, and as I mentioned, we do appreciate the report. Specifically for the dead beneficiaries issue, there are clearly things that we've done, like implement the federal data hub that allows states to check for death and other issues on the front end. We're also looking to work with our technical advisory groups with the states and recommend more guidelines for the states to access the right data and then access it frequently enough.
Okay. Now, GAO next recommended that CMS supply more complete data for screening Medicaid providers by providing states with full access to the Provider Enrollment Chain and Ownership System, or PECOS database. So again, Mr. Bagdoyan, can you describe the PECOS system? Can you comment on how states are using PECOS and why GAO issued a recommendation for CMS to provide additional guidance to states?
Sure. Thank you for your question. With PECOS, it's a situation where states would need access to the system electronically so they can be able to run batch searches, if you will. I know it's a little technical term, but right now they have to do a manual search on a case-by-case basis, each name, each time, in order to get a result, whether there is an issue or not. So that's the essence of our recommendation, is to get them the automated access that would allow them to do bigger and wider searches at once.
Thanks. Dr. Agrawal, what training and guidance has been provided to states on using the PECOS system, and what additional efforts will you be undertaking?
Sure. So we have 2 different kinds of access to PECOS. One that is the sort of provider-by-provider real-time access to the system. But since this analysis was done, we've also been making data extracts available to states so that they can use those extracts and compare them against their entire enrollment file. We have already made changes to those extracts based on state input and are looking to expand them as we go on. With respect to guidance, we do offer education in using CMS data assets to states through things like the Medicaid Integrity Institute. We also offer other technical guidance and sort of case-by-case help as needed, and states can contact us for that.
All right. Let me see if I get my third question. Given that Medicaid is a joint state-federal program, states have a very important role to play in preventing improper payments. It sounds like there's a fair amount of federal information available to states, but that not all states are taking full advantage of what's available. So I'll start with Dr. Agrawal. How can states be encouraged to use the data available to them?
Yeah, I think that's a great question. So there are data assets like PECOS and Paris where we know that all states have access. And I think part of getting them to use it is offering the guidance, offering the technical input to make sure that they are using the data in the right way and using it as frequently as they can. With something like Paris, for example, we were able to release guidance and ask all states to not only input their data every quarter, but also to use that data in their enrollment efforts every quarter.
Okay, and Mr. Bagdoyan, based on GAO's findings, how can the states more effectively use the data available to them?
Yeah, I think I would echo Dr. Agarwal's comments. I think if they are available, once they are available, they would be encouraged through guidance. They would be held to account to make sure that this works as intended. I mean, again, it's a partnership. It's a common model, if you will, to make this work.
Well, I just want to thank both of you. In addition to the important tools already added by the Affordable Care Act, I'm encouraged that CMS implementation of GAO's recommendations will further help state Medicaid programs in their efforts to address this persistent issue. So thanks again. Thanks, Mr. Chairman.
Thank you. Now recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. You know, one of the hazards of having been on this committee for a number of years is you see themes repeating themselves. And Chairman Murphy, I remember very well a morning in late September 2008 when we held a health subcommittee hearing downstairs, and we had some, I don't know, 8, 10, 12 witnesses. It was a pretty varied panel. Karen Davis from Commonwealth, Steve Parenti from the McCain campaign, the late Elizabeth Edwards was one of the panel members. And it was all a panel to discuss what is it going to cost to provide health care to everyone who lacks health insurance in this country. And the estimates were quite varied. And they ran from $60 billion a year to $800 billion a year. Chairman Murphy, I remember you asking the question, how could there be so much variation? And Steve Parenti on the panel was the only one willing to take it on and said, well, if you provide Medicaid to everyone, and that's how you expand your coverage, that's the lower number. If you provide federal employee health benefit plan to everyone, which was being talked about by some of the candidates at the time, that's the higher number. So I guess my point is everyone knew going into everything that became the Affordable Care Act that the way to expand coverage without blowing up the cost was Medicaid expansion. Why wouldn't you fix some of these problems before you undertook to expand a program that, if I understand correctly, Mr. Bagdoyan, it was already on a watch list in 2008 and certainly on a watch list in 2009 when the law was written, in 2010 when the law was signed. But really, why not put the effort on the front end? The way we're going to expand coverage is through Medicaid. Maybe we could deal with some of these problems. What about the fact we got dead people that we're paying money for? What about the fact we got people who are receiving benefits in 2 states simultaneously? That's not supposed to happen, is it, Dr. Agarwal?
That's correct.
The whole issue, GAO in 2005 or 2006 put out a report about the third-party liability. Medicaid will pay a claim when a person has private health insurance. And really, Medicaid is supposed to be the payer of last resort, not the payer of first resort. And we've never really satisfactorily dealt with that problem, have we?
I'm not familiar with the report, but
Well, I will tell you, no, we have not. So here are 3 very basic steps. Don't pay the dead people. Don't pay people twice. And, hey, if Aetna, United, Cigna is supposed to be paying the bill, you get them to pay first before the state reimburses on their Medicaid system. Relatively simple steps that could have been done before expanding a program massively. And now we're in a situation where not every state has expanded their Medicaid. And Dr. Agarwal, let me just ask you, when states come in with their proposals, if a state is considering expanding Medicaid in their state, and some states are, whether I think that's correct or not, some states are, when they come in with those proposals, are you talking to them about the fact that there are some inherent problems in the Medicaid system and we would like to see those fixed before you double your number?
Yeah, thank you for the question, Dr. Burgess. So I think our relationship with the states is such that we're talking to them regardless of whether or not they're seeking to expand their Medicaid programs. There are current program integrity challenges and vulnerabilities, as the GAO has pointed out. They exist in the current Medicaid program. Our state oversight efforts, whether it's the PERM rate or state program integrity reviews, include all states, not just those that are expanding. I think, you know, to your larger point, what we are trying to do is balance real program integrity interests and needs against the needs of a socioeconomically disadvantaged population that needs access to health care and health care services.
Let me stop you there because the time is going to become critical. In my opening statement, I referenced a problem that was related to dental care in the state of Texas. And you got a real problem. People who should be barred from ever participating in the program again simply dissolve into bankruptcy and reemerge in someplace else. And what are you doing to keep that from happening?
There are clearly efforts that we have. You know, we do conduct collaborative audits and investigations with states, and where appropriate, encourage states to take termination actions in their programs. I think you referenced the exclusion authority by the HHS OIG. We obviously, you know, agree that that's a very powerful authority. We encourage OIG to implement it where appropriate, and where they do, we can take revocation action quickly behind it.
Let me just, before our time expires, Dallas Morning News over the weekend, an article that I think is part of a series of articles about how private nursing homes are drawing down dollars by combining with a public entity. And some of these are fairly low ratings on the star rating on the nursing homes. Are you working with the states to address this problem?
Yes, I'm not aware of the specific nursing homes, but you know, we do have survey and certification and other rating functions to CMS that can work with states on these issues.
Well, $69 million just in these nursing homes identified last year, so it's a place where we need to put some effort. Thank you, Mr. Chairman. I'll yield back.
Chairman yields back. Now recognize Mr. Kennedy for 5 minutes.
Thank you very much, Mr. Chairman. Thank you to our witnesses for coming today and for your testimony in an important hearing. I want to touch base a little bit on the improper payment rate and put that in context. Medicaid program provides about 70 million low-income and disabled Americans with vital health care services, and we must do everything we can to strengthen it and protect it. No one, as you've heard from my colleagues here this morning, no one, Democrat or Republican, is in favor of fraud. We clearly want to make sure this program is as lean as it possibly can be, and that the people that need help and need the services are getting them. So to that end, Mr. Bagdoyan, I'd like to begin with you. Since its peak of 9.4% in 2010, the improper payments rate for the Medicaid program has steadily decreased, reaching a low of 5.8% in 2013, or $14.4 billion. That number rose to 6.7% in 2014, or $17.5 billion. Is that right?
That's correct, sir.
So I want to dig into that number a little bit deeper and see if I can better understand the dynamics that are in fact driving that improper payment rate. The ACA provided CMS with a number of new tools to strengthen program integrity in the Medicaid program. In 2011, CMS established a new risk-based screening procedure for Medicare, Medicaid, and CHIP providers. CMS also promulgated new regulations requiring states to use electronic data maintained by the federal government to verify and revalidate beneficiary eligibility through the Data Services Hub. So, Dr. Agarwal, let's break down that payment rate a little bit into its relevant components, and I know you touched on this a little bit earlier. But if I understand this correctly, the Payment Rate Measurement Program, or PERM, measures error rates both overall for the Medicaid program as well as for certain subcategories, fee-for-service, managed care, and beneficiary eligibility. Is that right?
That's correct.
So what's happened to that beneficiary eligibility error rate since 2011?
I think that's an important point, and it does highlight some of the intricacy in the rate. The beneficiary eligibility error rate has actually been cut in half since 2011.
So the error rate for beneficiary eligibility rate cut in half, declined by 3%. Is that a substantial improvement, major improvement, small improvement? How would you characterize it?
I think given the issues that GAO has highlighted, it's obviously a substantial improvement. More work remains to be done, which we are focusing on, but it does indicate good progress. And
so what's driving that improvement then? Is it likely the result of, in your opinion, the work CMS has been doing to implement the new program integrity tools in the ACA? Is it something else? What's behind the success?
I think it's work that being done at both the federal and state levels between increased collaboration, more education and technical guidance going to states, better data assets that have been highlighted by Mr. Bagdoyan.
And if, given that large drop in the error rate for beneficiary eligibility, what factors are driving the increase in the overall perm rate? And I realize you touched on this a little while ago, but if you could flesh that out a little bit for me.
Sure, no problem. The biggest driver of the increase in the rate are provider enrollment and screening standards. And again, as with other PI aspects of program integrity, whenever there's a new requirement, certain stakeholders, in this case states, can experience some difficulty in keeping up. So what we have found that while some states are quite far along, other states are lagging behind, and generally that is causing the error rate to rise.
And how do we get those other states to pick up the pace?
Well, we exercise oversight in a variety of ways, so I think it's both what can we offer them in terms of collaboration that will help, like technical assistance, data assets like PACOS, and then where can we exercise real oversight. We do that through the perm rate. We require states to submit corrective actions to improve the error rate going forward, and also conduct state program integrity reviews with associated corrective action plans where states fail to meet requirements. So I think it's a mix of both of those things. You know, I think the error rate increase in that particular aspect is the reflection of more stringent policy, which in and of itself is a good thing. We need that policy.
What, if anything, can this committee do to help you with that?
You know, I appreciate the question. I think holding our feet to the fire is appropriate.
You're welcome.
Thank you very much. I also think, you know, encouraging states to stay on the right path, take advantage of the various resources that we offer, identify improvements that we need to make so that they can make progress would be extremely helpful.
And again, just putting this in context, if I understand, Mr. Bagoyan, the GAO report, it was 4 states, yes,
yeah,
and covered 9.2 million Medicaid beneficiaries, right?
That's right.
And I know we've talked a little bit about the 200 or so deceased beneficiaries that received payment. If we were to put that, just so I understand it, that's 200 out of 9.2 million, right?
My math is not that good.
Right. If we wanted to put that in that percentage, though, if you take my word for it that my iPhone calculator ain't so bad, that is 0.000002. 4 zeros and then a 2174. As far as error rates go, we're nothing is acceptable, but we're doing okay if it's 200 out of 9.2 million, right? You guys are doing your jobs?
Well, that's what we found is 200 out of the 9.2 million. That's all I'm prepared to say.
Well, thank you for your work on this. Thank you for your research and being here today and highlighting an important issue for the hearing.
Thank you.
I guess this can go in the category of lies, damn lies, and statistics. But we appreciate no matter what it is, and we're all in agreement on that. We want to make sure we read that. Dr. Bouchon, you're next for 5 minutes.
Thank you, Mr. Chairman. First of all, I was a practicing physician for 15 years, as I mentioned to our witnesses beforehand. I've taken care of all patients, regardless of their ability to pay, which is what we do in healthcare. But I just want to highlight that all is not rosy with Medicaid. And I know this hearing is about waste and fraud and abuse. But I'm from Indiana, and our medical practice routinely wrote off hundreds of thousands of dollars from a neighboring state Medicaid program in billings every year because they ran out of money before the end of the year, and this predates the ACA. The other thing is that the program within our own state has been financially challenged historically with a significant Medicare provider cut within the last 10 years just to stay afloat. That said, Medicaid is a critical program that we have to have for our citizens. What can we do? Well, Indiana has expanded our Medicaid program using an innovative plan called Healthy Indiana Plan 2.0, and I'm hopeful that this state-based plan, as well as state-based plans around the country, can be used as a proving ground to how to move forward on our Medicaid program. Some facts about the Medicaid expansion that are not surprising to me, but seem to be surprising to those who wanted to expand traditional Medicaid, is that ER visits are up, and in some cases dramatically up, in multiple studies across the country. And why the hospitals are very happy, but we have made no progress because this is the highest cost form of medical care available in the country. And so, you know, having a card in your pocket but having no access to primary care physicians or others outside of the emergency room is not progress. And the encouragement to seek preventive care, as was mentioned earlier, may be technically true but functionally not accurate because you can't get preventive care if no one takes your coverage. States that have expanded Medicaid have already started to look for ways to pay for the program once the federal money for the expansion goes down to 90%. And my concern is reimbursement cuts will be the way that will happen. And what does that do? Further limits access to the citizens in their states. And if anyone doesn't think that sometime in the future that that the federal government will look for a way to pay for other things by further cutting that expansion money to the states on their Medicaid program, then I don't think, you're not following the government very well. That said, I do have a couple of questions, and again, this is a very important hearing. I saw that. We limited the study, Mr. Begoyan, to the 4 states. Why did we pick these states, and did the GAO try to include other states in your study?
Thank you for your question, Dr. Bouchon. The way we picked our states is we began with the universe of beneficiaries per state, and then we also looked at data reliability as well as geographic dispersion. So those were the 3 key factors that we used to pick these states, data reliability being a very important factor. We don't have reliable data, we can't do our analysis.
And that segues into, Dr. Agarwal, how do you envision, the data we were just talking about not accurate from states, how do you envision the progress we're making in information sharing on Medicaid between the states and the federal government? How can we improve on that situation? So if in the future we want to study this situation, we can pick any one of 50 states. How are we doing?
Yeah, thank you. I think that's a really important question. Data is really central to program integrity work. What we have found is access to the right data set can really increase the sensitivity and specificity of our leads. The agency has made some of the biggest investments we've ever made in improving Medicaid data assets in programs like TMSIS, which is seeking to dramatically increase the amount of data and the kind of breadth of that data that we get from state programs. In addition, Congress has funded previously programs like the Medi-Medi, which encourages Medicare and Medicaid data sharing and integration specifically for program integrity purposes, and we've been engaged in that process for years now.
Is proprietariness amongst different systems a problem? What are the barriers to, it seems like it'd be simple, right? But there are barriers.
There are, and I'm not a technologist, but there are clearly differences between systems and getting data integration to occur. That's not a trivial task at all, especially, amongst 50 different states. So, yeah, there are some real technical barriers to getting the right data formatted in the right way so that it's readily accessible.
But some of it's not just about money, right, where the systems don't want to communicate because of proprietary control over data?
I'm not sure how much proprietary issues stand in the way. I think it is more technical implementation. And then, yes, resourcing is important to make sure that we can adequately make this all work together.
Thank you, Mr. Chairman. I yield back.
Ms. Clark, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and I thank the ranking member, thank our witnesses for their testimony here today. I'm glad we've had the opportunity today to talk about the Medicaid program and how many people it helps across the country. As of February 2015, over 70 million people were enrolled in Medicaid. The number of enrollees will continue to rise as 30 states have expanded Medicaid and even more states are considering doing so. We know that fraud and improper payments have long been a reality of the Medicaid system, but with the passage of the Affordable Care Act in 2010, we've made significant steps to strengthen the Medicare, Medicaid, and CHIP programs by reducing waste, fraud, and abuse. Dr. Agarwal, I'd like to ask you about the Affordable Care Act's anti-fraud measures and how they have strengthened the Medicaid program. In your testimony, you noted that the Secretary of HHS can temporarily pause enrollment for new Medicaid providers and suppliers if she determines certain geographic areas face a high risk of fraud. Dr. Agarwal, how does the Secretary make that determination?
Yeah, thank you. So you're right. The moratorium authority is one of many tools granted to CMS for its program integrity efforts. We currently have moratoria in place in 7 different metropolitan areas in 2 main service categories, ambulance services and home health agencies. And we arrived at those areas, both the service types and the geographies, by doing data analysis to look at where there was clear areas of market saturation of these provider types. And in all of these metropolitan areas, we see somewhere between 3 to 5 times higher the number of providers of these categories than comparative metropolitan areas. We also conferred with our law enforcement colleagues in DOJ and OIG to assess where hotspots really are and where billing is, really concerning for fraud. And it was really a multitude of things that led us ultimately to implement these moratoria.
And how does the Secretary, how have they been effective in preventing and reducing fraud in those affected areas?
So what the moratoria really do is essentially pause enrollment. It stops new providers from coming into those areas in these specific provider categories. That affords both us and law enforcement the opportunity to step up our activities in those areas and remove bad actors that are already in those areas prior to lowering the moratorium and allowing new providers to enroll again.
And has that been effective in your estimation?
I think we're still doing data analysis to look at how effective the moratorium as a singular tool is, but what we're finding is that in those areas, which clearly are hotspot areas anyway, we've been able to effectuate literally hundreds of revocations of both home health agencies and ambulance companies. So we continue to assess the moratorium. We're obviously very concerned about access to care, want to make sure that the moratoria don't interfere in access. And so there's a lot of analytics that go on, as well as collaborating with the states.
And how does the affected states during the moratorium period, how does CMS work with them?
So we engage, just as we do more broadly, we engage in data exchanges. We work with them on collaborative audits and investigations, and then we do those access to care analyses to make sure that the moratorium is not having an adverse consequence.
Yeah, and on that point, how do you make sure that Medicaid beneficiaries are continuing to receive the services they need?
Right, that's of primary importance. Again, these areas and service categories were chosen in the first place because of really significant market saturation, making access not such a huge problem right at the outset. But as the moratoria have gone on, we've worked through our regional offices at CMS with the relevant states. We've stayed in contact with them, exchanged data to make sure that that picture has not changed, and thus far it hasn't. Access to care continues not to be a major issue.
And then finally, ACA significantly increased funding to fight Medicare and Medicaid fraud. How will additional funding help CMS address program integrity vulnerabilities?
Yeah, we do appreciate the work of Congress and the leadership of this committee in providing more resources for us. Those additional resources will allow us to continue to invest in existing programs to encourage, again, more data collaboration with Medicaid agencies, provide more technical guidance and education, and then where necessary, especially to respond to recommendations like this, we will be implementing new initiatives and programs to continue to tighten the Medicaid and Medicare programs.
Very well. And just out of curiosity, the implementation of the data hub, have you used that collaboratively in those high concentrated metropolitan areas as you also employ the moratoria?
Well, the data hub is really more of a general federal asset for states to utilize at the time of beneficiary enrollment and eligibility determinations. It's not really specifically focused on moratoria area. Rather, we see it as a tool that should be utilized across the program, across the Medicaid program, to ensure eligibility is done correctly the first time.
Very well. I yield back. Thank you, Mr. Chairman.
Now recognize Ms. Brooks for 5 minutes.
Thank you, Mr. Chairman, and thanks to our witnesses for being here. I'm a former United States attorney, and so have worked with Medicaid fraud control units run by our state's attorney general, and also with HHS OIG agents. And my question is really to both of you about the staffing and the number of people that we dedicate. So while you're very focused on prevention, I understand, but deterrence is also a wonderful tool, and I'm curious about the effectiveness of our deterrence. Because if we don't prosecute those, and while certainly I know U.S. attorneys' offices and attorney generals are prosecuting all across the country, I don't believe they have the resources that they need. These are very complex investigations. The last thing they want to do is prosecute someone wrongfully, and these are very complicated cases. So my question is to both of you about how whether it's our healthcare providers or the beneficiaries who are receiving improper payments, what is your thoughts on how we are doing with respect to prosecutions?
So I appreciate the question. Prosecution is obviously an important aspect of healthcare fraud control generally. Well, what we have been doing over the last 5 years since the creation of the Center for Program Integrity is really investing resources in preventing these issues from arising in the first place. That includes, payment edits, audits, investigations, and ultimately removing a provider from the program if necessary to stop inappropriate billing. As part of that work, we are also collaborating closely with OIG and DOJ, making sure that they have data that is adequate for their cases, providing them what additional services or resources they need, even using administrative authorities that CMS has, as long as we're obviously following those authorities and implementing them in the proper way. So I think it is a balance. I think deterrence is obviously very important, and we continue to collaborate with law enforcement as needed.
Mr. Burgoyne?
Yes, thank you, Ms. Brooks. The issue of prosecution was not within the scope of our audit, certainly, but I would see it certainly as part of the toolbox that I alluded to in my opening remarks. So in its totality, it would have to have preventative controls and the ability to investigate and, if appropriate, prosecute. So.
Let me dig a bit further on the investigation, though, because you have to do, and I've seen the reports done by those units and the analysis they do, and it's very complex. And I know that in your written testimony, you talked about the Medicaid Integrity Institute, Dr. Agarwal. How many employees do you know across the country deal with Medicaid, state and federal? Any idea? Because I saw that in the testimony or in a Reuters report that more than 4,200 employees have been trained, but there are thousands more, I would suspect, but I have no idea.
Right, so I'm not sure exactly what the total number of Medicaid employees is. I think the 4,200 number, what that really sort of refers to are state employees that we've been able to bring over to the Medicaid Integrity Institute to engage in an educational experience on some aspect of program integrity, whether it is working with law enforcement or provider enrollment and screening standards, beneficiary eligibility, whatever the case may be. I think there certainly there are definitely more than 4,200 out there. Right now our only constraint is the resourcing and the time to get as many employees in as possible. But the program is a strong one, I think, because it really allows us to spend federal resources. States have to pay very little to nothing for an individual employee to be educated and have access to those courses. And
are all the courses required to be done in person, or could you move to an online training program to help states who have, constrained budgets have more of their Medicaid employees trained?
Yeah,
I think that's a challenge for a lot of states.
Agreed. That's a great question. We have, up until now, done the vast majority of this education work in person, because there is a value to that in-person education, being able to conduct seminars, real sort of small group trainings. However, I think your point is a good one, and we are currently looking at ways of using more virtual training, as well as potentially putting MII on the road, so that states that can't travel or for their own policies or whatever still have access to the education.
Do you have any sense as to the success of this institute? I mean, how many folks have gone back and have actually prevented fraud?
Yeah. So measuring the impact of education, as you are probably aware, is really challenging to connect it to specific dollars and cents that are saved. What we find in certainly post-course assessments is a very high rating by state officials that indicate that they really did value the education that was given. We do also ask them to self-report where they feel the education contributed to recoveries or savings. We can give that number to you. But again, I think it's hard to connect education to a specific dollar that is saved. I think it's often important to do these activities merely because that greater awareness at the state level is valuable unto itself.
Okay, thank you. I yield back.
The gentlelady goes back. Now recognize Ms. Castor for 5 minutes.
Well, thank you, Mr. Chairman, for calling this hearing, and thank you to the witnesses. Thank you for your attention to program integrity and rooting out fraud in Medicaid. In Medicaid, every dollar counts because these are dollars that go in large part to children and their health care needs and our older neighbors in nursing homes and other hardworking Americans. Now, CMS has issued several new regulations and guidance just in the past month, and I'd like to ask you about them today. Dr. Agarwal, as I understand it, under the proposed regulation for Medicaid managed care organizations, managed care providers would be subject to the same screening requirements as providers for the fee-for-service program. Is that correct?
That's correct.
And that's especially important because many states are moving their Medicaid programs to managed care models. Is that right?
That's correct.
In fact, do you know how many states have already shifted and have instituted Medicaid managed care?
I think the majority have. They're at various levels. States like Arizona, where it's essentially all managed care at this point. Other states that have a hybrid population between fee-for-service and managed care. But that kind of enrollment requirement is a vulnerability or an issue that have been flagged by both OIG and GAO, and so we were happy to get into a proposed rule.
Okay, elaborate on that. Why did CMS make that decision?
Yeah, so as you mentioned, the rise of managed care is definitely occurring in all states, with some at various levels of integrating managed care. Previous OIG and GAO reports have highlighted that as an issue because up until now, providers that provide services in managed care programs, through MCOs, aren't necessarily known to the state. They don't necessarily have to go through the same enrollment standards. Some states require that, others, most don't. We felt this was an important vulnerability or an issue to address, hence that was that's sort of one piece of the program integrity provisions in that NPRM. And we think that requiring the same screening standards will ensure beneficiary safety regardless of whether they choose to stay in fee-for-service or managed care.
Good. And Mr. Begdoyan, is this a policy change that the GAO supports?
I'm aware of the rule coming out, but I'm not familiar with its details. I would go back to my original point that steps like this one would, over time, if executed and sustained, help narrow that window of opportunity for fraud and improper payments. So that would be my assessment at this point.
Okay. Dr. Agarwal, my understanding is that the proposed rule also imposes new internal compliance and program integrity requirements on Medicaid and CHIP managed care plans. Can you walk us through those requirements?
Sure. There are other requirements of managed care plans that include elevating issues or informing the state about audit issues, other vulnerabilities that they have identified, and making sure that they have compliance programs in place to ensure the integrity of payments, program integrity generally. Those are all new elements that the majority of states don't have. In addition, there's a data sharing element which requires language in managed care contracts to ensure states can still get access to managed care data as needed for program integrity and other purposes. So I think that the NPRM, obviously we're in sort of the rulemaking process, but if finalized in its form, would make really important progress in program integrity.
And your goal is to complement what is already in place at some states. Some don't have the similar safeguards. Is that right?
Correct. You can sort of think of this as trying to build the safeguards in place that have been started in fee-for-service. So the same screening and enrollment standards, the same kind of access to data, and making sure that those go through to managed care plans. So again, beneficiaries have the choice for which to engage in states that have both, or states can make the transition to managed care without necessarily feeling that they have to give up program integrity along the way.
Okay. I'd also like to ask you about the guidance CMS issued earlier this week on criminal background checks and fingerprinting of certain providers in the Medicaid program. First of all, who will be subject to the full background check and fingerprinting requirement, and how will CMS and state agencies determine if a provider represents a high risk?
Sure. So you're referring to fingerprint-based criminal background checks that were one of the ACA requirements in enrollment and screening for providers. Generally, fingerprint checks are utilized for provider types that are designated high risk. That would be, for example, a newly enrolling home health agency or DME company where there has been a history of kind of endemic fraud issues. If you are newly enrolling in the state in one of those categories, you'd be subject to a fingerprint-based criminal background check. If CMS has already done it, states can utilize our results as their own. The only other provider types are those that have already designated, been issues to the program, and therefore are on an individual basis designated high risk if they try to re-enroll.
Thank you very much.
Thank you, Mr. Mullen. You're recognized for 5 minutes.
Thank you, Mr. Chairman. Doctor, can you walk me through the process of what happens when a state medical fraud unit identifies a provider that's committing a fraud within the system?
Broadly speaking, I can. I will sort of tell you the steps that I know, but I'll just make the point that MFUCUs, the Medicaid Fraud Control Units, actually respond to the Office of Inspector General, and they work with program integrity units at the state Medicaid agency. But surmising that the relationship is really similar to what we have with our Office of Inspector General, we will often initiate investigations based on data assets, beneficiary complaints, a host of other inputs. And then if there's any indication of fraud or patient safety issues, we will send that over to the OIG, and oftentimes state Medicaid agencies have similar policies engaging their fraud control unit.
Can the state medical or Medicaid fraud units indict providers?
I believe they can, working with regional DOJ offices.
With our communication with our Oklahoma fraud unit for Medicaid, they indicated that they couldn't. They had to basically turn it over to you all.
Again, they might be referring to federal law enforcement, either, again, OIG or DOJ. As an administrative agency, we don't indict providers. We have various administrative authorities and actions, but the most severe is kicking somebody out of the program.
So they can go in and be fraudulent and billing Medicaid for millions of dollars, and the worst thing that happens to them, they get kicked out of the program.
Well, again, we have the administrative authorities that we have. We are able to suspend payments, terminate the enrollment of providers. And then I think, to the point that was made earlier, we do work with law enforcement to bring other, more criminal justice activities.
But we hear reports over and over again about providers that were kicked out of the program for having fraudulent claims, and then they turn back around, change their name, and they're back in business the following week. So what's the indicator that you communicate with the federal prosecutors and say, look, we want this guy to go to jail?
Right.
Or do you guys just don't do that? You say, well, whatever. You guys, he defrauded she defrauded the taxpayers millions of dollars, but it's up to you.
Well, specifically with working with law enforcement, we make referrals, I think hundreds if not thousands of referrals, and we can actually get you some numbers for the last couple of years to show you how many, to law enforcement for those cases that are most concerning for fraud and where we believe a law enforcement action would be appropriate, at least from our determination. But I think to your larger question about providers kind of reinventing themselves, we too have noted that as a vulnerability and in fact have promulgated rules that have allowed us to close it by, for example, tracking administrative actions and actually applying them to owners who would try to reinvent companies.
Well, it seems like to me if more went to jail, that might prohibit them from going through. So do we know how many actually end up in doing jail time?
I think that's a question for at least the OIG or the state law enforcement officials.
Is that a number that you guys could provide?
We don't track. Remember, our authorities don't involve.
So there's a breakdown in communication, is what I'm saying.
No,
well,
no,
there
I
has
wouldn't
to
say
be,
that,
because you kick them out of the program, then turn it over, and then no one pays attention to them anymore. And if the federal prosecutors aren't willing to prosecute, then they come right back into your system. No one's paying attention to them, and they end up doing the same thing over again. Because if the worst thing that happens to them is they get kicked out, then it's not there. Maybe it might be something that we might want to look at. Maybe we ought to let the states do this. If they have a unit that specifically identifies claims to Medicaid that the state is issuing, and they see fraudulent activities, and they turn it over to you, you all kick them out, they turn it over, you all turn it to the federal prosecutors, they end up getting lost in the chain. Why don't we simplify the process and just let the state prosecute them?
Well, just to be clear, states don't have to go through CMS in order to get to prosecutors or law enforcement. They do have Medicaid fraud control units that they can go to directly.
But they
have other avenues that they can
prosecute them, though.
Right. As administrative agencies, the state Medicaid agency, CMS, we don't prosecute directly, but we do work with law enforcement to do that. I wouldn't characterize it as a communication breakdown. I'd characterize it as different lines of authority. We are happy to work with law enforcement. We provide law enforcement with data on a routine basis, work with them sometimes for years as they develop, investigate, and take action on cases.
So do you think there's a better way, quickly, and because I ran out of time here, is there a better way to handle this then?
I think it depends on what the this is that you're trying to improve.
Well, to prosecute the individuals rather than just kicking them out of the program and not actually sending them to prison.
Yeah. I think there's a balance. So it's really important, I think, to engage in prevention because prosecution takes, understandably, time. And what we don't want is folks billing programs that shouldn't be billing programs. And so it is useful to actually kick them out of the program and stop dollars from going out the door. At the same time, if we can work with our law enforcement colleagues to get the prosecution, we can have the deterrence effect and other impact that we want.
Appreciate it. Thank you.
Thank you, Mr. Green. You're recognized for 5 minutes.
Thank you, Mr. Chairman. Ms. Magadian, the Medicaid is a large program, as is Medicare. And would it be fair to say that as long as these programs existed, there have always been at least some improper payment, some people gaming the system?
That seems to be the historical record, sir, yes.
I know it wasn't part of your audit specifically, but improper payments were not only associated with Medicare and Medicaid, but it's a challenge to our government-wide, I assume.
That's correct. OMB measures that. I think maybe the chairman or the ranking member earlier referred to the higher error programs that OMB tracks, so yes.
Okay. Clearly, we want to lower the rate of improper payments in the programs such as Medicare and Medicaid, but it's important to put it in context. This committee examined this issue more than a decade ago. Then, like what we're discussing today, there were improper payments associated with Medicaid and Medicare. But do we want to constantly try to eliminate improper payments? And we do want to try and eliminate improper payments and better controls. On page 14 of your report, your audit mentions that CMS is, as part of the passage of the Affordable Care Act, has put in place some new tools that may help bring down improper payments. And I realize the gaps remain, but do you see this as an important step in the right direction?
I would say they are, and they add to their toolbox that I referred to in my opening statement.
Okay. Do you see any new tools as a step, the new tools as a step in the right direction? If so, can you explain how you think they will help us reduce the improper payments moving forward?
Well, the two recommendations we make available to states where the action happens, so to speak, with the data they need to better screen both beneficiaries and providers.
Okay. I understand more specifically that CMS, through the new regulations, established a more rigorous approach to verify financial and non-financial information that could help determine Medicaid beneficiary eligibility. It's created a tool called the Data Services Hub. I know that gaps will remain and bad actors constantly try to find ways to game the system. However, does the implementation of this new tool, the Data Service Hub, give you some encouragement that we can reduce the rate of improper payments?
Again, by all means, it is a step in the right direction. Getting the data right and reliable is a key step there, as well as having states' regular and electronic access would be also useful.
I'm guessing some of these new tools are already having some positive effect. I understand that GAO's audit has some limitations associated with it, mainly due to using data that's now almost 5 years old. While I applaud GAO's efforts to help strengthen Medicaid through its work, it's unfortunate we're not see how these new and encouraging tools are working until we can examine more recent billing data. Mr. Chairman, I hope that we would continue to work with GAO and CMS and see how these new tools CMS is working on that can help us in taking out the fraud and abuse. And again, I want to thank GAO for the excellent work you've done, and also CMS for responding to what we did in the Affordable Care Act to give you those tools. And I yield back my time.
Gentleman yields back. Now recognize Mr. Collins for 5 minutes.
I come from the private sector. I'm a Lean Six Sigma guy. I've brought Lean Six Sigma into a large municipal government. I think you all both know where I'm going. It's not a good place. This is the most disturbing hearing I've attended in 2.5 years. I hear you saying that making 67,000 errors per million opportunities is worth a gold star. Six Sigma says you make 3.4 errors per million. 3.4, not 67,000. I will be using today's hearing in my stump speeches, in my town halls for a very long time. It's everything wrong with government. That you're setting a standard of making 67,000 mistakes for every million times you try to do something, and you're going to reward and congratulate yourselves. This is disbelief, absolute, utter disbelief of what's wrong with government, to have you two individuals with smiles on your face in congratulating each other over trying to achieve 67,000 errors per million opportunities. I'm just, my mind's blown. You know, I know if 1,000 airplanes take off and 67 of them crash, that's a 6.7% error rate. I don't think we're going to be flying on our airplanes if 67 airplanes crash for every 1,000 that take off. In the manufacturing world today, whether it was Toyota many years ago, whether it was General Electric, or what it's some things I've done, we set a goal of 6 Sigma, 3.4 errors per million. It's achieved every single day in the private sector. And here we are in government talking about 67,000 errors per million opportunities and how this is progress. This is disgusting. It is a waste of taxpayer dollars. It's setting the bar so low that, yeah, I guess, you know, we had a goal of 5.6. We had 6.7. So next year, let's make it 6.7. Well, if it's 7.2, then the next year it's going to be 7.2, and we're going to have a hearing, and you guys are going to self-congratulate each other on achieving something like that? I don't even know that you can't defend the indefensible. So while I'm carrying on here a little bit, I know you can't defend the indefensible, but maybe I'll let you try, and I'll also say there's a sign in my office. In God we trust. All others bring data. I'm a data guy, if you can't already tell. That means you need good data. And now I'm reading that the PERM program, the Payment Error Rate Measurement Program, at best, it's using a rolling sampling of 17 states. The data is not consistent. It's not gathered in a consistent way. I have one word for that data, and it's garbage. Garbage, complete garbage. So, I don't know, Mr. Bagdoan, do you have anything to say?
Well, Mr. Collins, I thank you for your comments. I think our audit was thorough by our audit standards, and our findings speak for themselves.
I mean, you're familiar with Six Sigma, right?
Yeah, I am indeed. Yeah.
All right. So in my world, what would you think if you're in my world and I'm used to 3.4 errors per million and you're at 67,000? How long do you think you'd work for me?
I take your point.
Yeah, not very long. And Dr. Agrawal, again, you seem okay with taking the 5.6 to 6.7. Can you defend that? I'm going to stand up in front of my residents and I'm going to talk about this hearing, and they're going to be shaking their heads in total disbelief. You're going to be an example of everything wrong with government from this day forward in Western New York. When I tell them at 5.6%, you hit 6.7, so the next year you just changed it to 6.7. If that's not, oh my God. I'm just, again, this is the most disturbing hearing I've ever taken place in. So what do you say to the third graders when I tell them that?
I think I made it pretty clear from my opening remarks, Congressman, that we do view these findings as important, and while we have made progress, there is more progress to be made. I don't view it as any other way. I don't view it as just sort of being happy with the results and where we are.
Well, my time's expired, but I'd suggest you set different standards for yourselves, ones that respect the B in billions. We talk in government about dollars like billions don't even matter anymore because we're trillions in debt. And I would suggest that as somebody who's got something to do with this, next year when they try to raise the error rate to 7.2%, you actually stand up and make a name for yourself and say, I'm not going to stand by and let that happen. With that, I yield back.
Chairman yields back. Just to clarify, Dr. Ardwell, did you set this standard at 6.7%?
No, that's a process that involves a different part of the, it's obviously kept separate from folks that are trying to make the interventions, right, so that there's some objectivity to it.
And Mr. Bedoyan, you more or less audited this information and provided it for us, correct?
We use it as a point of reference, sir. We don't set the number.
So as a follow-up to Mr. Collins' question, it is important for us to know the process of how that's done, because I think you heard unanimity of opinion. None of us want to tolerate that. But we need to know how that's happening so we can make changes on this very thing. But I thank you. And now recognize Mr. Yarmouth for 5 minutes.
Thank you, Mr. Chairman, and thanks to the witnesses. I want to get some clarification on this perm rate because I'm not sure I understand it. If you characterize these as errors, are these errors that CMS made, or are they errors that in which just some kind of incorrect payment was made? So you would have had, for instance, a bill come in that was coded incorrectly, wrong procedure, whatever it is, and would that have been counted as an error?
Yeah, it would be.
So it wasn't a mistake that you made. It was a mistake that somebody who was sending the bill in made. Is that correct?
Yes, I mean, I think it could be argued, and in fairness, that we need to have preventive programs in place to catch that.
I understand, but this is not necessarily an indication of negligence on the part of CMS.
Correct.
And I've got my problems, as everybody does with CMS. But so if somebody sent in a bill on a fee-for-service basis that for $100, and they were actually only entitled to $90, that would be an error under this report.
Correct.
Now, would that total $100 be counted in the $14 billion? My point being that I think there's the danger here, and I'm a former journalist, there's a danger here that somebody would look at this report and say, the mistakes cost taxpayers $14 billion in 2013, when in fact they didn't cost taxpayers $14 billion. They cost them could be a very small fraction of $14 billion. Am I analyzing that correctly?
Right. I think what's really important is the measured tone that GAO and Mr. Bagdoyan have taken today, that these are all potentially improper payments and not, the data inconsistency alone doesn't absolutely establish that. In many of the specific claims where these improper payments have been noted, states or CMS are able to actually recover those dollars, or federal portions are withheld. So, yeah, there is obviously complexity underlying this that you are correct to point out.
Right. I just want to make that clear because, again, I think there's a danger in taking these numbers and blowing them out, at least with not a full understanding of what they represent. And Mr. Bagdoyan, looking at the numbers there, I did the same calculations that Mr. Kennedy did. And on the deceased question, and look at it another way, it was 1 out of every 46,000 beneficiaries. Just on the total beneficiary problems, it was 1 out of every 742, and on the provider problems was 1 out of every 2,753. So I think, again, there's a danger in looking at it and saying, 8,600 beneficiaries got benefits in 2 states, but it is a relatively small number. I would be negligent if I didn't spend time talking about the Kentucky experience because I know my colleague from Indiana talked about how states are worried about paying for the Medicaid expansion. I think everybody has some concern over what the impact will be, but in Kentucky, I need to congratulate Governor Beshear and his team. Under the expansion, Medicaid, more than 520,000 Kentuckians now have insurance who didn't have it before. The ACA, the uninsured rate across the state's been reduced by almost half. In my district alone, the uninsured rate's been reduced by 81%, which is a phenomenal occurrence and I think a very humane one. But more importantly, the governor just had the Deloitte firm, highly respected accounting and business consulting firm, do an analysis and a projection as to what the ACA would mean to Kentucky over the next 6 years. And again, most of this is because of Medicaid expansion. The vast majority of the newly insured are part of the Medicaid expansion. The Deloitte firm concluded that over the next 6 years, the ACA in Kentucky would create 40,000 new jobs, would have a positive impact on the economy, additional impact on the economy positive of $30 billion, and would have a positive impact on Kentucky's budget over the next 6 years of $819 million. So, I think that it's easy to sit here and say, gosh, what are states going to do when they have to pay 90% in 2021 or 95% in 2017 or 18? But in fact, an analysis of our situation shows that it's going to have a positive impact well into the 2020s. So I wanted to get that on the record as part of this discussion. So with that, Mr. Chairman, I yield back.
Gentleman yields back, and I recognize Ms. Blackburn for 5 minutes.
Thank you, Mr. Chairman, and I thank you all for being here. And as Mr. Collins just said, this is really a frustrating hearing in so many ways. For us, in 2003, shortly after I came here, we did a field hearing in Tennessee looking at the TennCare program, which was the test case for Hillary Clinton's health care and implemented in Tennessee, and a lot of Obamacare has been built on it. And one of the focuses of that hearing was the waste, fraud, and abuse, and the fact that CMS just couldn't seem to get its act together when it came to dealing with waste, fraud, and abuse. And when you isolated our state and looked at it, the payment error rate and the eligibility issues with the verification of who was and was not eligible, and then the providers. And so to see this continue on and your willingness to accept a failing grade in addressing this is just beyond us. Because you're not getting better, you're getting worse, and then you change the grading system to accommodate that you are not improving. And Dr. Agrawal, if I'm understanding this right, you moved from 5.6 to 6.7 in that rate, and this was done by committee, so there's no one person in charge of this debacle? Is that correct?
I'm sorry, ma'am. I don't understand what you're asking about.
You changed your grading rate. You went from a target for 5.6, a target rate, to 6.7 in your improper payment rate. And if I'm understanding your answer to Mr. Collins, there's no one person that decided that. It was a committee or a group that decided that. Is that correct? Who do we hold responsible for accepting a failing grade?
Well, Congresswoman, clearly the target is set, but I think what's important is we actually measure our performance.
Who set the target? Who set it?
I don't know. We'd have to go back and identify that person.
Who accepts the wasting of taxpayer money? You've got an issue that gets worse every year. Let me ask you this. We're going to get in behind this. You've got, was it 90 providers in one state that were found to be receiving erroneous payments? Did I understand that right, sir?
Sorry, it was 90 in the 4 states we looked at.
90 in 4 states.
That's right.
Okay. What would happen if we were to say there were a zero tolerance policy for improper payments and for waste, fraud, and abuse that's taking place in CMS? What would happen? How would you all react? Because federal agencies that deal with taxpayers, they pretty much have a zero tolerance policy. Or what if we did this? What if we were to look at these numbers? According to CMS, improper payments in the Medicaid program rose from $14.4 billion in 2013 to $17.5 in 2014. What if we were to say, CMS, we're going to charge you back with this $17.5 billion until you can get your act together? And you've got to take that out of your budget. And you've got to find a way to deliver the services and avail yourselves of technology. Let me ask you a question, too. When it comes to the data and transferring that into information that can be used, have you looked? You say you offer guidance and support to the states. Have you told the states we're going to hold you accountable for giving us data that can be turned into information, and we're going to cut your payments if you don't give us the data that can be used? Garbage in, garbage out. It's not going to change. And the fact that you have a secure job and a paycheck and think you can't be fired, and then you come in here, and what we hear is, going back to my first hearing on this in 2003, the problem gets worse, the problem doesn't get better, and when it does get worse, you just change the metrics and say, well, that's okay. We're going to do better next year. No, it is not okay. The error rate is not okay. And it's something we're going to push forward in holding you all accountable and look for new ways of doing that. I yield back my time.
I'm going to yield it back. I'm going to let Ms. DeGette take 2 minutes, and Dr. Burgess 2 minutes, and we'll proceed from there. Thank you.
Now, in fairness, Dr. Agrawal, were you in your job in 2003, in this job?
Nope.
Mr. Bagdwan, were you in this job in 2003?
I was not, ma'am.
I'm going to ask you because you're with the GAO. Have they has the agency tried to institute new metrics to try to prevent fraud since 2003?
I think as we reflect in our report and in my statement, they have. Those will have to play out over the long term.
Right, and
as impact at all.
And as we discussed when I was asking questions, unfortunately, the data that you had for those 4 states was from 2011, so it didn't reflect some of the preventative efforts that have happened since then.
That's correct. That was part of the necessity of our methodology.
Right, exactly, because you just didn't have the data, right?
That's correct.
And Dr. Agrawal, do you think that it's a good idea to have fraud? Do you support that? Because I've been listening to these other questioners. They seem to somehow imply that either you personally or the agency think that it's acceptable to have fraud.
Obviously, I do not.
Why?
Well, I come at it from the perspective of an ER physician. I've taken care of Medicaid and Medicare beneficiaries and other beneficiaries, the uninsured. I do this work so that we can preserve resources for the folks who need it.
Thank you. I yield back.
Dr. Burgess?
Thank you, Mr. Chairman, and I do thank our panel for being here, and I know it's been a long morning. Let me just ask a question because I'm trying to get a better understanding of the what's referred to as the PERM program. That's a 3-year rolling average of 17 states examined on a yearly basis. Is that correct?
That's correct.
And now, what kind of statistical modeling was involved in coming up with that formula?
So there is a statistical sample done in each of these states along the 3 major categories of the PERM program. And again, we conduct the cycles so that every state is measured at least once in the 3-year period. And there is statistical analysis behind it to make sure that the results are generalizable and can actually arrive at a national rate.
How do you select the 17 states to be in the particular cohort?
They're
alphabetical, and then you cut it off at 17? And
that's a good question. Actually, I'm not sure. I don't think it is alphabetical, but there are 17 in every cohort, and we make sure that every state is represented once in a 3-year period.
So the 4 states that Mr. Bagdoyan was concerned about, are those 4 states all in one cohort, or are they evenly distributed between the three rolling averages?
They're distributed between them.
Well, I guess, it seems like that's a difficult, I don't understand why that model was selected. Is it just simply too difficult to assess every state on a yearly basis?
I think it would be a real resource constraint to try to assess every single state every single year, and it does also pose burden issues for the states.
Everybody knows HHS has the best computers in the world, right? So why can't you?
Well, I can take that back as a specific question if we're going to alter the methodology, but I think the methodology itself is not the sort of under scrutiny or question here.
It just struck me as unusual to do it in this fashion. So again, that's why I was wondering, is there a particular statistical methodology that has been followed as far as the sampling on a rotating basis, 17, 17, 17, year in and year out? And how long have you been doing it this way?
Since the PERM program started.
Which was?
I believe we had the first rates in 2007, but I'd have to get back to you about that.
And do you see consistency in those numbers over those years that you go back and look at this?
What we do is we report a national average rate, every single year, so you can actually follow the rates as people have done in this hearing, sort of talk about the rates over time. What we don't report are rates by state because it is very difficult to compare 2 different Medicaid programs that might have 2 very different approaches to eligibility and other things.
All right. Thank you, Mr. Chairman. I'm going to submit a question in writing about the Dallas Morning News article that I referenced earlier in the hearing, and I would appreciate a response on that. Thank you.
Thank you, Dr. Let me just say this. I mean, you heard a number of, first of all, we're grateful you came to us in a candid way. But I think you hear among us, we want to facilitate this. None of us are going to tolerate any kind of acceptance of this. And there's a concern about whoever made the decision to just raise the level is not really acceptable. What we want to know is the methodology and work with you and see what next steps we need to take to deal with fraud and abuse. Granted, this data is from 2011. Some changes, as Ms. DeGette pointed out, may have already been put in place. To whatever extent you can tell us about that, we want to move a trajectory towards this because goodness knows federal dollars are limited, and anybody who's out there being a crook needs to be handled appropriately so the money can go to those who need it. That's where compassion should be. It's sort of in the category of those who can, those who can't, and those who won't. And those who won't play by the rules, they need to face the consequences. So we'll be passing on other questions to you, and to that extent, I want to thank the members for participating, and when other questions that are submitted for the record, we'd appreciate if you could get back to us with prompt responses. So to that extent, I now adjourn this hearing. Thank you.